Professor Roman Zachoval, live from Prague, Professor at Charles University and head of the Czech Urology Association. What are you working on at the moment? Which is the area that particularly interests you within urology in your practice at the moment?
What I am focused on at the moment is oncourology, especially prostate cancer. It wasn't always like that. I started with functional urology many years ago when I finished university and started my as a resident and fellowship. And I still do a lot of functional urology at the moment. Our department is the leading department in the Czech Republic that performs the surgical treatment for male stress urinary incontinence. So we do a lot of urinary sphincters and tapes and slings, mostly adjustable at the moment. So I'm a big fan of adjustable devices. And so I'm working on that, just functional urology, especially incontinence, but it is also urology. We are the only department in Czech Republic that have an office in the unit. It is a rehabilitation unit for spinal cord injury patients. So we actually copied the departments in the Western Europe. We made a tour with my colleagues in the Western Europe many years ago, and we saw these institutions in many countries like Great Britain and France, Germany, Switzerland. And we try to make a copy of that in Czech Republic.
Urology in terms of incontinence, I would argue, has gone backwards rather than forwards from a point of view of innovation. Meshes have gone. A lot of places have taken this to mean that slings are also not to be used. We are back. Well, the sphincters from AMS, they paid my mortgage for a number of years, but they were invented in the 1970s. And we're doing birch colpoplasty again. Where's the innovation? Is the innovation in rehabilitation, or is the innovation in new technique? Where's the innovation around incontinence?
Yeah, I have to agree with you that there's been not much so-called clinical development in the recent years, but there's a lot of things going on in the scientific field. So the scientists are trying, urologists with collaboration with scientists, they are trying to improve all the diagnostics and especially treatment that we have for the functional disorders, like incontinence, like a hypocontractility of the bladder, the new drugs for over or underactivity of the bladder. So I think there's a lot of things scientifically going on, but there's not much yet in the real clinical practice.
Yeah, it's a strange one because what little bit of urology I did 20 years ago at the Whittington Hospital in London and UCL in London, places like this, we did TURP all morning and TURB all afternoon with a monopolar loop on a resectoscope. But there's been some huge innovations. If we talk prostate, you guys have 1,000 different ways of ablating, removing, magicking away the prostate tissue now for BPH. And then, of course, robotically, the robot was supposed to be the area of the neurosurgeon or the cardiac surgeon or all these guys doing a much sexier part of the world than urology. But somehow the urologists have stolen a march here, and you have some wonderful innovations surgically. But it seems at the functional end, we're still using Botox for hyper mobility in the bladder. Where's the next thing coming from? What's the next thing in incontinence? What do you think it will be?
Coming back to the functional urology, just the BPH is still part of the functional urology.
Yeah, of course.
Robotic surgery is mostly used for the oncological diseases, but BPH is, it's a matter of functional urology. And
what are you
as you
using?
mentioned, as you remembered me, we have a new techniques, new methods. It is actually, it is still a question if the URP is a golden standard for the surgical treatment of BPH. It may be being removed or is going to be removed, replaced soon by new mini-invasive approaches like laser therapy. We are also only department in Czech Republic that have both used lasers for BPH. So we use a green light laser mostly for small, large prostates, and holmium enucleation of the prostate for just the middle size and large prostates. So I think this is real improvement for the patients.
My colleague from AMS Times, who is still a colleague of mine now, Mr. Steve Aldous, was the green light laser guy. So he will be very pleased to hear that this is still going on nicely in Prague. Dr. Gomez-Sancha, a big fan of removing the prostate with a laser.
Actually, yeah. I'm closely collaborate with Cesare Scofone from Torino.
I know him too.
So we're good friends, and we work together. And he has done just like 1,000 procedures. So I still have to learn a lot from him. It's good to have a tutor like him. Yes, but it is not only about lasers. We've been using Resume for 2 or 3 years here in Czech Republic, and I've been doing it for 1.5 years, and I'm quite satisfied with it, and patients as well. It really works, and I haven't evaluated my results, but just from experience, I have a few dozens of patients, and it really works with the 5 years follow-up. So we see just the 5 years, the procedure is comparable with URP or laser methods, both concerning the efficacy and both the complications. So, but it is minimally invasive.
Yes.
It is a one-day surgery, or maybe it can be also in the outpatient office surgeries.
It seems from speaking to your colleagues globally that to do less but in a more targeted fashion is the surgeon's aim at the moment. The same with the general oncosurgeons, that to do less but in a more targeted fashion, to take less tissue away but to take the right tissue away. What about visualization? The hand cannot remove what the eye cannot see, and yet we're all still looking down a scope. It's a bit better than looking down it with your eye, and the cameras have got better. Where do you think visualization is going?
I think it is. It's been improving stepwise all the time. The visualization just many years ago, visualization was not as good as now. And the improvement in the technique itself, just of the visualization, digitalization, and the optic fibers and so on. It's much better than we had before. And also we have these new 3D techniques in his 3D laparoscopy or just robotic surgery, and enlargement of the operating fields by the looping.
Do you use some augmented visualization in your tumor surgery? Are you using Hexvix or narrowband imaging or any of these things?
Yes, we use a narrowband imaging standardly when we perform the resection of the tumor cancers. Hexvix we don't use much because of the reimbursement here in the Czech Republic. It's a problem of costs. In the recent years, I moved a lot of to the onco-urology, that it's been improving and developing more.
I'll challenge you on that one then for bladder at least. What little bit I did in the mid to late 90s and 20 years before that, we treated tumours of the bladder with transurethral resection and either BCG or chemotherapy. It seems that we've moved on enormously, and now 40 years later, we treat it with transurethral resection of the tumour and either BCG or chemotherapy. Is that it? Is that where we're going to end up?
But I think there are new approaches in the site. Yeah, a lot of small tumors are resected with the unblock resection. So we don't cut the tumor in pieces. This is not oncological approach generally. Yes. This is actually something special in urology. You cut the tumor in small pieces and take it away. Just
and helpfully reseed it for future work in 2 years' time. I think that's an issue. Yeah.
On the other oncological surgeons in other specialties, they always want to remove the whole tumor and then not to cut it in parts. So if this unblock resection in small tumors,
if you're provided with a bag, like you're doing a lap chole, and they gave you a little bag to put it in, would that help? I'm designing products on a beer mat as we go here, but would you like a little surgical bag to put your unblock in? Would that help?
Maybe. We should.
Okay, well, I'll write that one down. We can call it the Zachoval Cooper approach or the Cooper Zachoval. We'll have to argue about the billing, but we'll discuss the fine. Okay. Let's look at it a slightly different way then. What's your big research area at the moment?
In a functional urology, it is mostly just we do a lot of research in the spinal cord injury patients. At the moment, we try to find the urinary microbiota. This is special for this type of patients, and if it influences the natural course of the disease. And
give me now, as I apologized at the start, I'm only a failed orthopod, so this is complicated for me. Give me you're explaining this to an orthopedic surgeon over a beer. Explain to me what you're looking for here. This is new to me.
Microbiota is a microbiome. It's actually all the spectrum of bacteria or viruses that you have in a tissue that you examine, or in the sample you examine. So it can be urine, it can be blood, it can be tissue, and we try to find out what is this microbiome in it. By just to explain it, if you try to find out what infection is in urine. You take a urine sample and you send it for microbiological testing.
Mm-hmm.
They put it on a special surface and try to find out what's going on. But it is only about 10 to 50 ordinary bacteria, common bacteria. But it's been found out in the recent years there are much more than this. There are dozens, but they are in small amounts, and you can find out. But this not the standard methods. You have to use special methods. Yeah.
Mm-hmm.
And
what's this
you
leading
find
you
out
to?
really all spectrum of bacteria you have in urine. Yeah. Mm-hmm. And it is a very popular issue, scientific issue now everywhere. You can examine not only urine but also sputum, stool. Yeah, it is big issue in gastroenterology. Yeah, and so on. And it looks like just these bacteria can influence the natural course of the diseases.
It is thought that the natural biome, or perhaps an infective biome of a patient, may lead to either protection from or worsening cases of, up to and including prostate cancer, bladder cancer, and anything else you can throw your hat at.
Exactly.
Whew.
The protection is more about the worsening of the problems, or maybe resistance to special kind of treatment. Example, for overactive bladder, you give some drugs. You can have botulinum toxin and others. Neuromodulation, have neuromodulation and others. And maybe just if these methods are not effective, maybe it can be caused by some types of bacteria you can find by these new methods. Yeah.
Okay, that's and then the treatment of those bacteria, or the eradication, or even the propagation of those bacteria, might lead to different curative states.
Exactly.
Okay, goodness, it's every day is a school day. This is like being I suppose if you interview a professor, you're going to learn something.
This is one thing in functional neurology. In neurology we do. The other things is I'm in a few working groups to try to improve the implants for the surgical treatment of stress urinary incontinence. Both sphincters and tapes. Yeah. So as I said, I am a big fan of adjustable devices.
Yes, either through adjusting
and maybe telemedicine.
Yeah.
Yeah, which can be probably in the future used for the sphincters. Now the sphincters are operated manually. But this is some limitation in patients with some impaired manual dexterity and some cognitive problems. And if we can switch it somehow to telemedicine in urology, actually, it doesn't work much yet in urology. The other specialties are probably more advanced, more forward, just in front of us. And we don't have any device that is operated by the remote control. So, but these sphincters might be the first devices that can be operated like this. Yeah.
Whether you have an app on your phone, or you have as you say, telemedicine. So everybody knows that at 10 a.m. it's pee time, and you have to go to. Of course, when I worked for IMS, we had many discussions about this in the related area of impotence implants, that an app on your phone or perhaps a beeper like you have for your garage door might be a way forward. But there's a serious point that, I mean, I've certainly seen enough failed
now you have just a
applications.
lot of devices that really just, of course, at the beginning, it is always a little bit disappointing somehow, because it takes time to make it work good. But now you can see in diabetes, in the ear surgery, and other things, just that these remote control devices really work.
As a disease, well, for incontinence as a disease of the more elderly people, if they have cognitive or physical disabilities that stop them, and we know from using a pump, using a sphincter with an implant for control can be incredibly difficult. We have a story, I don't know how true it was, of a patient in South Africa who said he couldn't operate his sphincter, but it was incredibly painful. And instead of pressing on the pump, he was squeezing his testicle in order to open it. But it's an area that if we can remove some of the technical challenges from it, we can aid the patients with exactly what we're looking for. I have recently won the European Super Lottery, as I'm sure you've read. So I have 100 billion euros of research money that I'm more than happy to donate to Charles University. What are you going to spend it on?
Yeah, just a lot of things.
No, I'll only allow you one thing.
Too many choices. Can I have two?
Go on then. Just because I know, Roman, you can have two.
Yeah. Just like as a surgeon, of course, I would like to have some perfect robotic system for just the operation, for making the procedures. Just, we operate by robotics now mostly, but still robotics, it is improved laparoscopy somehow. It has some disadvantages. You don't have a feeling of the tissue when you operate the system, and so on. So if you can make the system really perfect, just in all senses that the human can use, so I would probably invest the money in it. Yeah,
I'd certainly come and be the sales director for you. I think that sounds very reasonable. So we have the stranglehold of Da Vinci from Intuitive. The CMR, Cambridge Robotics, is starting to be placed now. There's a new system coming from Medtronic. Yeah. So what do you want? Do you want visualization? Do you want haptic feedback? Do you want 3D reality? Do you want to be completely removed from the operating theatre and be in a room on the other side of the world? Where's the next step?
Yeah. Just work from your home office. Yeah.
After the pandemic, all urologists will have a robot installed in their spare bedroom and they'll work from home. Yeah. Which is the next thing, do you think?
I would invest it in the research on the development of the urological cancers, just the oncourology in the recent years really moved forward, just progressed a lot. And now we have a close collaboration with oncologists. We also make a treatment as the clinical oncologist for the prostate cancer, somehow from the bladder cancer. So it would be something in this area. Yeah. Mm-hmm. There's a lot of new drugs, that can influence these urological cancers. So it would be something something with it. I don't know what exactly.
No, yeah, I'm not asking for
But
specifics. I'm not
generally,
taking notes,
just
but
the research in oncourology, just to maybe in prevention also, yeah, just to decrease the risk of these diseases and minimize the treatment burden and so on.
a lot of your colleagues have discussed urinary biomarkers at this stage, specifically in your oncology, because we still tend to have a fairly blanket approach. Now, if I don't remember any urology, I remember even less medical oncology. But the discussions about chemotherapy choice in bladder cancer in our area, well, everybody uses mitomycin because everybody uses mitomycin. Or if mitomycin is too expensive, we use epirubicin because it's the same as mitomycin. I suspect it isn't. Or we use gemcitabine because that's available and inexpensive, and it's the same as mitomycin and epirubicin. I suspect it isn't. This looks like an area where more research is needed.
Yeah, I agree, and even I would go even to the step before it. I'm involved a lot in the awareness of the urological cancers. I just actually work a lot of the prostate screening project at the moment, which is the hot tissue in the EU at the moment. And also in Czech Republic, there should be a pilot project for the prostate screening here in Europe, one of the countries. So I'm trying to push it forward. I also
that's a biopsy screening or a urinary biomarker?
No, just PSA screening.
Just from PSA. Okay, we get a PSA screen in the UK. I was 50 this year, and both my father and grandfather had CA prostate, and I can remember enough genetics that I have a passing interest in my PSA at the moment.
I'm not sure. Just according to what I know at the moment, there's actually no systematic screening in any European country at the moment. Just systematic screening. It means that just some state institution sent you a letter, and you are between 50 and 70 years of age, and you should come to the GP or urologist for the PSA sample. And so so this is what we try to make now here in Europe. I think it is the way we can move forward in the developed countries. Of course, it doesn't work much in the undeveloped countries, but in the developed countries where you have the possibility to finance it and to have a big recruitment of the man or female for special disease, it must be over 50% of population and so on. So it can be successful. This is it is just another aspect of the fight against the cancer. Yeah.
And what should we do for bladder? We're lucky in a way that we have PSA testing for prostate. Occasionally, somebody will talk about hematuria in the press, or a famous person will get bladder cancer, and you hear all of the British urologists cry out when they say on the news that if you get hematuria, you must go and see a hematologist, because the clinics then explode with urinary tract infections, prostatitis, and God knows what else. Is that the best we can do for bladder cancer? Just a bit of blood? What should we be doing?
I'm not sure. It's just I don't want just to judge the British healthcare system, but here in Czech Republic we really proceed according to the recommendations. So all patients with hematuria, either macroscopic or microscopic, should go to see the urologist for the endoscopy and ultrasound or CT scan. Especially, at present, just many people take drugs, just anticoagulants, antiaggregants, So, and of course, it can reveal some small cancers, just this loci of minor resistance in the body, So this is the strategy here in Czech Republic. In Great Britain, there are not so many urologists for the population as in Czech Republic and Germany. And in
Germany's that every shop that sells sausages and bread has a urology surgery above it in Germany. When you go to the German urology meeting, there's thousands upon thousands of them. It was very
and it's even more in Italy.
Final question then. So I will give you the keys to the DeLorean car from Back to the Future, and you set the date to 2050 and land in the urology theatres of Charles University. What does it look like? What's changed? What's the same? What will it look like in 25 years' time from today?
We still have surgical procedures. We still operate in the OR, but it will be mostly minimally invasive procedures, probably on the outpatient office and just the one-day surgery. I would like to have more awareness and prevention and diagnose the diseases on the early stage. We will have much more of medical treatment of the urological cancers. The surgical part will be smaller than today. It will be more medical, just chemotherapy, biological treatment, and so on, targeted therapy. So we will have more of that. And okay, I hope we still have some doctors and nurses in the hospital.
To quote from the last James Bond film, or the one before, regardless of all of the technological advantages, you still need somebody to pull a trigger occasionally. And there will always be room for surgeons, because you will always need somebody to remove something surgically. So I think this is...
There will still be need of that,
I think so.
And
most of the
we will have more lawsuits, of course. Yeah.
I will always have a need for lawyers as well. Is there anything else that you would like to say that you think I've missed?
What all of us missed a lot in the last 2 years was a physical contact among us all on the meetings and in the congresses. So I hope these viruses will not kill the social events and meetings, and because of course it is extremely nice to have a video call with you, but maybe if we have a beer,
it's much
in
better.
the bar, it would be even more pleasant. And also,
but we will be at EAU, and we have dinners booked for both the Saturday and the Sunday night. So come and see me at our booth at EAU. Okay, well, thank you very much, sir. Thank you for your insight. And certainly there's a couple of things in there that I'd never thought of, so it's very nice to hear of it.
Thank you, Guy. It was a pleasure